Okay, so in the course of our study, what we wanted to do is wanted to be able to take demineralized bone matrix, otherwise known as DBM, as a standard graph for ACDF, but understand that it's very much limited by donor availability and supply. The rationale behind what we did and what we want to do is we actually want to see how it is that bioactive glass, which is a fully synthetic option, which is also osteostimulative, can actually enhance fusion recovery times. The evidence gap with literature was pretty profound with us, because we found that there was a glut of literature with regard to DBM alone, but there's very little with regard to actual bioactive glass alternatives. So what we said was we wanted to fill that gap somehow by actually being able to create literature. So our objective first and foremost was to first study, compare the safety, efficacy, and radiographic outcomes of DBM alone as one group versus bioactive glass and DBM and 1 through 3 level standalone ACDF. So our methods, what we did was we took 3 prospective randomized trials between 2018 and 2022. And in total, there were 243 patients, of which each were actually blocked out and randomized into 81 patients per cohort for each final level. We randomized them by using block and Python technology coding, actually, into the 2 groups so that there would be minimal bias. We had a 2-year minimum follow-up, and our outcome metrics were fusion rate, early fusion timing, VAS, disability outside vascular pain, NDI for disability, as well as whatever the complication rate was. The fusion rates were actually 100% across all groups. Earlier radiographic findings showed BAG and DBM. BAG was greater than DBM alone. BAG actually had twice the amount of fusion and 36% greater fusion relative to DBM alone. The functional recovery rate was actually increased by 15 to 16%. There were no non-unions, graft-related complications for bioactive glass alone or implant failures. And we only had DBM only had one JC segment breakdown at the 3 level. And in conclusion, bioactive glass and DBM achieved equivalent long-term fusion, but earlier fusion and nearly double the early pain relief versus DBM alone. It provided a safe synthetic alternative that mitigated donor limitations and supported accelerated recovery. And the results fully endorse that DBM and bioactive glass is a clinically effective, biologically active substitute for allograft as opposed to just DBM alone, or standalone ACDF. Thank you very much.
Great, thank you. Next is paper 103 by Dr. Sombrano, comparison of electromagnetic and